I don't believe it's all the answer, because I believe that there are a lot of frustrated patients out there who are being told to think about their pain differently when there are actual real reasons they're having pain.
Welcome, my friends, to the Bob and Brad podcast. My name is Mike Kienitz, and today I am interviewing physical therapist Rick Olderman, and we are talking about chronic pain issues and specifically his new book coming out, Pain Patterns. Thank you for joining us, Rick.
I'm excited to be here, Mike. Thanks for having me.
So, for the people that don't know you and our numerous podcasts we've done, would you mind telling us a little bit about yourself?
Yeah, I'm a sports and orthopedic physical therapist for almost 30 years. I owned my own physical therapy practice here in Denver. I sold that about 2.5 years ago, and now I'm which gave me time to work on this book. And actually, I co-wrote a book with Bob and Brad called Top 3 Fix. And so I've been busy writing books during this time and doing a lot of telehealth. And we'll get into that, but that's kind of informed how I wanted to approach this book.
So you've done numerous books in the past. I know you have online programs, the one with Bob and Brad. So why did you decide to write another book called Pain Patterns?
Well, so this is my 9th book. And the first 6 books were all about specific recipes of exercises to help people solve problems in their body and their back pain, hip pain, what have you. But what I found, and those have helped lots of people, but what I found is that there is a larger framework that not only people with pain are missing, but also medical professionals are missing in understanding. For instance, if this one particular exercise doesn't work, they weren't given a way to think about why it wasn't working and what else they needed to try or modify or do so that it would work or move or have permission to move on to something else. And so, like I said, I sold my practice 2.5 years ago. So I've been doing a lot of telehealth. And because I wasn't able to use my hands to help solve pain like I did in the clinic. Now, I'm not a strong manual therapist, but I did use my hands to work with people. It forced me to really go into this paradigm of how do I get to this information that I know will help this person without actually touching them? And so that's basically, so over these past 2.5 years, I've been distilling more and more of these telehealth visits information down to these tests and I realized, oh my gosh, yeah, the pattern that I've used to solve these people's problems are that I first identify the pattern of pain that they're having. And that tells me where to start looking in terms of understanding what other problems they're having, how that's feeding those patterns. And then I, basically became pretty good at figuring this all out without even touching people and just doing the tests via telehealth. So that's how this book is structured in terms of the workbook section, is that first you identify what patterns you have that are causing your pain. And then you identify why those patterns are happening, the components of those patterns.
So who is this book written for? Is it the practitioner or the layperson or everyone and anyone?
It's a little bit of both. The primary goal of this book is for people with pain. And that reason is because most practitioners don't give a crap what I say. Doctors, PTs, chiropractors, no one, really cares. So, because everyone has already bought into their particular approach to solving pain, and most practitioners aren't willing to step outside of that. So they're locked in. So why try and change someone who doesn't want to be changed? But people with pain are highly motivated to change. And so that's where the thrust of this book is for. And that's especially why, I have the workbook section. And when I say a workbook section, you will actually write your answers to the test down in the book, because there's too much for you to hold in your head and understand all at once. I want you to be able to go back and look at your answers so that you can say, because the way it usually works, Mike, is someone has an idea, they think that they know why they're having pain. And so they'll focus on one exercise or maybe 2 exercises or things. And when that doesn't solve their pain, they then walk away. But this book will help you see, oh, if those 2 haven't helped, then, oh, I had these 3 other problems that I didn't think really mattered to my pain. But now I'm going to go back and try those too and see if those help. And lo and behold, usually they do. So it's organized in that way so that people can go back to it and review and rediscover sources of problems. That's for the layperson. For the medical professional, the first section lays out the anatomy, the neuroanatomy, the neurophysiology of these three patterns, how I've put them together and why I've put them together. And I've cited a lot of research to support the existence of these things. And so that's more to appeal to the medical professional so that they get the buy-in. Oh, there's a lot of science behind this that's researched. There is. The only thing that hasn't been researched is putting it all together in this framework. And so that's what I've been doing these past 20 years. So having said that, the first section has a whole bunch of, complicated terms, and we'll probably get into some of those terms. But I don't want that to scare lay people away, because at the end of each of those chapters, I highlight just 3 or 4 concepts that I want you to take home from this. It doesn't matter that you understand what transforming growth factor beta 1 is. I don't care. It doesn't matter whether you know what a dorsal column medial lemniscus pathway is. It doesn't matter in solving your pain. I'm just using a lot of these terms to add depth to your understanding, because there's a lot of lay people out there who have a keen interest in their anatomy and physiology and have a science background and are really interested in this stuff. And then there are people who are just going to say, just give me the stupid exercises to solve my pain. And so I've tried to appeal to both of those groups of people.
Yeah, I was reading the first section and I was like, this is like I'm in school again and I forgot half of these terms. And then once I got to the second part of the book, I'm familiar with a lot of your work. So I was like, okay, this is the stuff I understand more, but it's good to have both.
It really is. You're not the only one, Mike. I mean, I revisited a lot of my initial schoolwork in PT school to pull out some of these ideas. I'm just like, oh, I remember some idea. And then I would go down that road and find that. I'm just like, oh, yeah, that does fit into this paradigm. So it's not like I'm taking all of this crazy out of this world information out there. I'm taking stuff that we've all learned to some extent and put it together in a functional model for practitioners and patients to get better.
So, how do the ideas in this book align with current direction of physical therapy?
Well, the current direction of physical therapy seems to be going, and this happened without my being really aware of it because I'm so used to working in my own little cave. It seems like physical therapy is going towards this cognitive behavioral therapy approach. And this was recently most forcefully told to me by the editor of JOSPT, Journal of Orthopedic and Sports Physical Therapy, because I tried to submit a blog article for that magazine, and it was rejected in part based on the fact that physical therapy is moving in this direction. And I understood that was being a part of therapy, but I didn't realize that it was so strongly moving in that direction. And by cognitive behavioral therapy, what we're really talking about is, how pain messages are created in your brain and how to manage those messages and things like that. And it seems like we're getting away from actually testing the body to understand exactly the functional reasons why people are having pain. And I think this shift has happened, Mike, because we have been so unsuccessful as a field of medicine in solving musculoskeletal pain in terms of chronic musculoskeletal pain, because we all have tons of back pain patients and sciatic pain patients and SI joint pain patients who have been all over the place trying to find solutions, and our solutions haven't been working either. And so being musculoskeletal experts, and we know all the names of all the muscles, we know the innervation of all the names, we know the names of all the bones, we understand how everything is put together, and still we can't figure out pain. So that must mean, oh, I wonder if it's in someone's brain then, because that's not something that we focus on. We can't change someone's brain. So we think that because we're the experts and we can't solve pain, it must be happening in their head. Well, that's in part true, and I explain in my book how that could be true. I don't believe it's all the answer, because I believe that there are a lot of frustrated patients out there who are being told to think about their pain differently when there are actual real reasons they're having pain.
Yeah, I've recently started treating patients again, and Bob and Brad are kind of retired, so it's a different practice, but it's a major hospital, and it's kind of interesting because a lot of the chronic pain ones, there's a few we can get settled down and they're good, but there's a handful so they just send them back to the doctor. They're like, nope, like just go talk to them, figure it out. Like they just seem to quit after 2 or 3 weeks.
Yeah, and so part of that is because we're ineffective, right? A patient I have found buys into what I'm doing when what I'm doing is working.
Yeah,
But if what I'm doing is not working and I'm just layering more and more exercises on top of them and their pain is staying roughly the same, why should they buy into me and think that I have the answers for them? And
sure.
so doctors, I've been told by several doctors who I've treated that they have hardly any musculoskeletal training. So it's not their purview to figure out musculoskeletal problems. That's when they refer on to surgeons whose purview is to operate on problems, structural problems. But that often doesn't work either.
Yeah, we have a good success rate post-op.
Well, the
That's more
success
cut and
rate
dry.
post-op could be better if we solve the biomechanical reasons for that structural problem in the first place.
Yeah.
If we have the same hammers after surgery working on that vulnerable area than as before surgery, why should you expect that surgery to last forever? Right? I'm not anti-surgery.
Hmm.
I'm very pro figuring out what the problem is.
And then solving it beforehand.
Yeah, and sometimes when we solve all those problems, you still have to have surgery because we can't overcome the structural changes that have occurred in your spine, right?
Yep.
That's when surgery is most successful because we fixed all of those. We know surgery is the only candidate. But so many practitioners, I think, are failing at solving chronic back pain or sciatic pain. And then they go to a surgeon, and while it works temporarily, that problem almost inevitably comes back a year or two later for a lot of people.
So I want to start talking about the first section in your book. You titled it The Body's Language. So this is chapters 1 through 5. And this is the in-depth, for lack of a better term, nerdy section of the
Yeah.
book. Do you want to explain a little bit more about that section?
Yeah. So I see pain as your body's way of trying to communicate with you that something's wrong. And usually when we strike on the thing that's causing that pain will immediately reduce. And so the reason I've called this the body's language is because section 1 introduces the vocabulary and the grammar by which our body communicates with us. This is what the body is trying to say is wrong. This is how it happens that it becomes wrong. And so this is the language that the body you need to know in order to understand why the body is giving these signals and trying to communicate these pain problems. And so I go into, you know, the way it's laid out is each chapter, the 3 chapters in the first section are devoted to different silos of problems that we in medicine investigate or research. The first chapter 2 has to do with movement patterns. And that's strongly based off of Dr. Shirley Sahrmann's decades of research and textbooks that she's written and courses that she's taught. And then the second silo is fascial researchers who study fascia, which is connective tissue in our body, and how that's all put together and works and integrates into our body systems. And the third is neuroanatomy or neurophysiology and what's happening over there. And over the years, I've found these common themes that are occurring in all 3 of these silos that none of these silos are communicating with each other about. Because apparently most people don't work in these 3 silos of information. But once I saw that there are almost identical patterns that are being identified in all 3 silos, and my book goes into what these patterns are, there's only 3 of them. that's when I put it all together and I said, and my section 1 is my attempt to put all of this information together in one cohesive model so we can understand what a problem is. And it doesn't matter if that problem is, caused by neurophysiology problems, fascial issues, or movement issues. It's all creating the same type of pattern of problems. And that's why I can distill it down to just 3 problems that we need to understand in order to solve almost all pain. Does that make
So
sense, Mike?
I've looked at the book, so I understand it. Yes.
Yeah. Okay, good.
So
That's a good start.
I want to talk about in chapter 2, you talk about the movement patterns, which you highlight are extension, flexion, and rotation. Can you explain how these can contribute to long-term pain?
Sure. So let's talk about extension problems because that's the most common one with chronic back pain. And on our podcast in the past, I've taken you through this test, but I'll take it through this with you one more time. And so extension problems simply extension means arching of the spine. All right. So an extension problem means that you have a problem with usually excessive arching of the spine. This is also referred to as lumbar lordosis. And so people with this type of posture pattern typically are those who have military erect postures, a lot of dancers, a lot of yoga people, gymnasts, people who have been involved with the military. Those types of people all have this military erect posture because that's what they've been trained to believe is the correct posture. However, if you also have a large belly in front of you, that belly will tend to pull the low back forward into this posture as well, creating excessive lordosis. Okay. Now, the easy way to determine this test from a movement standpoint is simply just lying on the floor. And this takes 30 seconds. So if you are watching this right now or listening, please just do this simple test if you have back pain or sciatic pain. So just lie on the floor. A firmer surface is generally better. That's why I say a floor. But if you can't get on the floor, then get on a bed. But you're going to have your legs straight, and we're going to stay there for about 20 or 30 seconds. And I want you just to feel how your low back feels in this position. Okay. Almost all of you with chronic low back pain already know that the answer to this test without even doing the test. So now that we've been here for a few seconds, now bend your knees so your feet are flat on the floor. One of these 2 positions, legs straight or knees bent, should feel better for your back. And 99% of those people with chronic back pain or sciatic pain will say, oh, definitely I love having my knees bent when I'm on the floor. And if you don't feel a difference, then go ahead and hug your knees up to your chest, hold them with your hands, and that should definitely create a difference with whether your back feels better with legs straight or knees bent. So what is this showing you? Well, when your legs are straight, your back has more arch in it. It's more extended. When your knees are bent, your back has less arch in it. It's more flexed or flattened. That's really simple. So basically, this is what an extension problem means. That if you have an extension problem, your back feels more pain when it's in an extended position than when it's in a flattened or flexed position, which this test is showing you. So already you've identified one possible pain pattern behind your back pain. And so the opposite of this would be a flexion problem, one with too little arch in your spine. And in the book, this is the category of problems that usually fits into flexion problems are disc issues. And usually these are acute disc issues. Most of you who have had acute back pain have gone to a therapist and they've had you go up on your elbows and go into this cobra kind of thing and do all of these kind of prone press ups, and that resolved your back or sciatic pain. Yes, that's because you had a temporary flexion problem due to a disc herniation or bulge. And that's what typically solves most disc herniations or bulges. But then a lot of you have said, oh yeah, well that acute incident went away, but now I'm left with this chronic pain problem. Well, that's because the overriding chronic problem is that you have an extension problem and you just happen to have had an acute disc episode during your extension problem. So you would then go back to extension exercises, extension problem correction exercises to fix the ongoing extension problem that you might have. Does that make sense, Mike?
That makes sense to me, but I also have heard this from you before.
Okay, so I forgot to mention the rotation problem too.
Yeah.
So a lot of people have gone to a chiropractor or physical therapist and been told that their spine is rotated to one direction. Oh, you've got a rotated L4 on L5 or L5 on S1, or L1 through L5 are all rotated. Well, rotation problems are one of the 3 patterns identified by Dr. Shirley Sahrmann. And usually you can identify this if you just take a picture of your back and you see a fleshier part of your spine on one side than the other. That typically indicates that the vertebrae are rotated into that direction. An easy way to determine if you have this, if you don't want to take a picture of your back, is simply cross your hands and rotate one direction and rotate the other. If you have a harder problem rotating to one direction than the other, you likely have a rotated spine. And so that is the 3rd pattern of problems from a movement standpoint that is behind almost all back pain.
So I want to talk about the next chapter, chapter 3. It's more about fascia. So how can fascia play a role in pain, and how can someone address it?
Okay, so let's go back to our extension problems. All right. So if we think that we have an extension problem, typically what's happening is that there's an overcontraction of the lumbar paraspinals and possibly tightness or other tightness and behavioral issues in the lower body system that are contributing to the pelvis tilting forward and arching the spine. Well, it just so happens that Thomas Myers did some brilliant research and discovered that we have these superhighways of fascia that start at the top of our head and go to the bottom of our feet. In terms of the extension problem phenomenon, we have one line of fascia called the superficial back line that goes along the whole backside of our spine, all the way down our legs and to the bottoms of our feet. So fascia is connective tissue, but it is closely associated with muscular tissue because it wraps around even at the cellular level and invests into muscle tissue. So if the fascia is contracted, it is also contracting back muscles too. And you can imagine that if all of your back muscles are contracting, it would create an extension problem or lock you into an extension problem pattern of movement. Because the fascia is not letting go, then you're locked in this extension. No matter what you do, your back is always arched a little excessively. So this is how fascia plays into this pattern of dysfunction. Now, in terms of rotation problems, there's a rotational line or a spiral line of fascia, and there is also a lateral line of fascia. And both of these play into rotation problems in the spine too. And I explain how that happens. We can go into more detail on that in chapter 4 if you want, Mike. But basically, and then there are, of course, superficial front lines, and then there's a deep front line of fascia that relates to flexion problems and likely disc issues. So from a very macro level, just knowing of these lines of fascia and knowing that our movement is reinforced by connective tissue that may be shortened that in a way that emphasizes how we are moving around during the day can lead to great insights as to other sources of your pain. For instance, since Thomas Myers identified that this superficial backline starts at your head all the way to the bottoms of your feet, any point along this fascial line will affect the fascia in the low back system. And any point above that fascial, even in the head, can affect the lumbar spine too from a fascial standpoint because it's all connected. The fascia, this superficial backline, Thomas Myers showed, can actually be dissected from the body as one continuous piece of tissue all the way from the top of the head to the bottom of the foot, which means it's all connected like that. Okay. So the other thing I want to throw in here, since we're talking about fascia, is that there's a type of fascia called myofibroblasts. Myo means muscle. And so this type of fascia has up to 6 times the contractile capacity of regular fascia. Myofibroblasts are laid down in areas of mechanical strain in the body. Well, our spine is composed of curves. So where those curves change is a natural mechanical source of strain in the body. Layered on top of this, if you look at the architecture, we have this large pelvis and small vertebrae. Well, that means that wherever this pelvis goes, the vertebrae have to respond to this, which creates another source of mechanical strain to the lumbar spine. And so it just so happens that in the lumbar pelvic region, there's something called the thoracolumbar fascia. That fascia has a high concentration of myofibroblasts in it. The myofibroblasts and that fascia has also a high number of sympathetic nerve fibers in it, which means it can sense pain. So what causes myofibroblasts to contract is not neural stimulation from our brain. For instance, if I want to bend my elbow, my brain is sending a signal to my biceps muscle to say, contract to bend that elbow. And it does it. And then my brain says, I want you to straighten that elbow. So now relax that biceps muscle and that elbow will straighten. So that is a neurological response here in my muscle. But myofibroblasts respond to hormone-like chemicals called cytokines. Specifically, the one that triggers myofibroblasts is transforming growth factor beta 1. So these hormones they're not hormones, but they're cytokines, are released from our nervous system when we are stressed. And for instance, if you suffer from anxiety, stress, PTSD, deep emotional trauma, things like that, then your body is releasing these cytokines, and these cytokines will gravitate towards the myofibroblasts, cause them to contract. Now, here's the interesting thing about myofibroblasts is that they don't have an immediate response like our muscles do to a neurological input. They have a long lead up to that contraction, and they have a long tail to that contraction. So that even after we tell our muscles to turn off, those myofibroblasts may stay turned on for hours and hours or days, depending on if we have a constant source of stressor in our system. And so the myofibroblasts, while they can't cause, I'm not using myofibroblasts to bend my elbow, I'm using muscles, but myofibroblasts have a deeper, slower, less mechanically engaged force of contraction in our muscles. So they add a layer of tension to an area that's already mechanically compromised. So that's fascia and myofibroblasts in a nutshell. And you don't have to remember all of the names of these things. Just know that this is possible, helps open people's minds to other possibilities of why they're having chronic pain. And so just like all the other chapters in my book, I have little key points that you can take away from each chapter to keep these basic ideas in mind.
I recognize the words you're saying, but do not ask me to repeat that. No, it's fascinating. I mean, most people think of injury as musculoskeletal or neurological, but I've never thought about cytokines or any of that. Interesting
No,
factors
and
to it.
so, there's so much in medicine. This is one of the reasons why I think cognitive behavioral therapy is gaining purchase, is because a lot of people are solving their maybe emotional components of their pain, like Dr. John Sarno's book, right? So, his big thing is, you solve your emotional issues and your back pain goes away. Well, yeah, that can certainly happen, but that doesn't address the biomechanical reasons why those myofibroblasts were set up in that region in the first place to make you sensitive to those emotional components.
Sure.
And so, and this is where I get later in the book, where you get to identify all the components. Is it how much of it do you think is movement? How much do you think of it as emotional? How much of it do you think is perhaps dietary that's contributing? And you actually categorize your issues to help you see what you may have been missing up until this point.
So that's a good segue into chapter 4, the brain body connection. So, how does your brain influence chronic pain, and how can we rewire it? Boy, that's a mouthful, to help with healing.
Yeah, so the brain is the ultimate controller of everything, right? And so there are nerve tracts that go down to and from the brain into different parts of the brain that control different things in our bodies. And so whatever we do with our body, there is this process whereby your brain is constantly gauging how you're, do I need to have 30 pounds of force to bend my elbow when I'm only lifting a 1 pound weight? Or can I modulate that to create the adequate force? And that's your brain having this interplay of messages going up and down saying, oh, I only need this much force to do this thing, right? I don't need, 30 pounds of force to do that. And so part of this equation is something called muscle spindles. Muscle spindles are mechanoreceptors that are built into our body that monitor all sorts of different things. All right. And muscle spindles monitor length and velocity changes in our muscles. And so if our muscle is lengthening too quickly, it triggers a muscle spindle to activate, which then causes that muscle to contract so it doesn't lengthen that quickly. And one of the most common examples of this is that knee-jerk reflex that we have. That if you've gone to a doctor, they've probably done that, where you sit on a table, they tap your knee, and your foot jumps up. Well, they're measuring the messages to and from your brain that your brain is giving your muscles and seeing if you are correctly wired well. For instance, if you have a problem up in your central nervous system somewhere, then you're not able to down regulate that response. And so your foot may jump way up or may get stuck in spasm or something like that. Or if you have no response at all, that may indicate that your peripheral nerves, the nerves that are exiting your spinal cord that go to your muscles, maybe there's a disruption there happening so that you're not having any neural response at all. So this is a basic test to determine the health of our nervous system. And fascia is blended into the capsule of the muscle spindle, as well as other mechanoreceptors as well. And so and muscle spindles is our brain's way of monitoring tension and length in our body, which is another way of saying that this is how our body understands how we are creating posture and proprioception, which is understanding if I close my eyes, I know my arm is straight now, and now I know it's bent. I know that because of proprioception, and muscle spindles are a big part of that proprioception, as well as other mechanoreceptors too. Well, fascia is closely integrated with both muscle and these mechanoreceptors. So you're not only affecting muscles when you are messing around with muscle spindles, you're affecting your fascial system as well. So if there's excessive muscle tension, then you're also having excessive fascial tension as well. And all of this is determined by basically how you're using your body. For instance, if you're lifting weights all the time, you see these guys who are all pumped out, right? And they have this incredible muscle tone. Well, that's just their brain saying, you know what? I don't think I'm going to turn off these muscles completely because you're constantly asking me to do something with them. And so I'm just going to keep these nice and toned and ready for work because that's what you seem to be asking me to do all the time, right? So these guys have a lot of muscle tone. That's what muscle tone is basically your brain never turning off those neural signals to your muscles and keeping some low degree of contraction happening there. And then your muscle spindles are monitoring whether there's, especially if you have a lot of muscle tone and you try to lengthen that really quickly, then that's going to be that's really going to trigger that muscle spindle response because it's saying, no, you've taught me to be here and now you're doing here and I can't let that happen. Well, that's also integrated with the fascial system. All right. So muscle tone, posture, proprioception, all of that is integrated and controlled by the brain, but it doesn't only affect the muscles, it affects fascia too. And therefore, and we've already shown that we have extension problems that have the muscles used in extension problems also coincide with the superficial back line and fascia. So when our brain is keeping muscle tension going in our back, it's also highlighting that fascial line and our movement line, our movement dynamics of how we move in or out of that posture.
That was a lot.
Yeah, it is a lot. But again, please don't be scared by that. So really, what I'm just basically saying is that your brain not only affects your muscles, but it affects your fascia. And so how you have used your body up to today has determined which muscles are going to be staying turned on, which muscles have been turned off all these years, and likely, possibly, where fascial tightness or restrictions have occurred because of all of that. And they all fall into these three patterns. So
Sure.
chapter 4 goes into, so So to go deeper into the reflexes, and I won't make it more technical, I promise. So it turns out that, we don't only have these unijoint reflexes, we have patterns of reflexes that occur in our body. One is, if anyone's ever come up to you and scared you, right? You've felt with the startle reflexes. It's when you do this and you kind of curl in, your shoulders bunch up, and you do that without your brain even thinking about it, right? You blink really hard, you contract and protect yourself. That's the startle reflex pattern. We have another one called the Landau reflex, and that's when we're babies and we're learning to crawl and we have to lift our head. That's the reflex we tap into to help us lift our head and arch our back in order to crawl and then walk. And then we have another one called a cross extension reflex. So if you step on a nail and it hurts, you don't wait for your brain to say, oh, you've just stepped on a nail, it would be a good idea for you to remove your foot. No, that foot comes up immediately. Well, in order for that foot to come up, we have to contract that whole side of your body to lift that up. But the other side of the body also needs to contract in an extension pattern to hold you up while that's flexing, or else every time you'd step on a nail, you'd fall down, right? So these are patterns of reflexes. The Landau reflex corresponds almost exactly to the extension problem identified by Dr. Shirley Sahrmann, the superfascial backline discovered by Thomas Myers. And so these all three they interlap, they overlap and have interplay with each other, so that they all are affecting some degree of that extension problem that you're experiencing.
So I want to dive into section 2, which is chapters 6 through 12. And I know chapter 6 is kind of mainly focusing on extension or flexion problems, which we kind of already hit. Is there anything about those you'd like to add, or should we go on to the next chapter?
Well, yeah, so chapter 6 is, so I want people to understand that I don't just have you test and then we move on, all right? So I have you test and then I offer a solution to what you've discovered that is, in my experience, is the thing that counters that pattern that you've had, or breaks it up, or offsets it, so that you're not experiencing that pattern to that degree anymore. And so it's important, though, this is where I think a lot of therapists are missing the boat, is that it seems like we're not testing as much anymore. And rather than assume what a problem is, I just won't assume what the source of someone's pain is until I test their body. And so we get in trouble when we assume. And so these tests are getting to the root of these three patterns for you. And that's what chapter 6 is, like you said, is determining whether you have basically a flexion or extension problem. And we just went over that test just a few minutes ago. It's the lay down test with the legs straight or knees bent. So you can even skip that one if you want to.
So chapter 7 and 8, you discuss side bending and lower body compensations. So what are some common signs that people may notice if they have these issues?
Yeah, so side bending problems relate to Dr. Sahrmann's idea of rotation spine. And they also bring in the fascial lateral line and the spiral line. Both of those lines of fascia have to do with rotation problems. And basically, in a nutshell, that's what it means, is that your spine is rotated to one direction. But what I've discovered is that you don't try to derotate a spine if you've got a spine stuck in rotation. What is driving the rotation is the fact that your spine is side bent. And so there was this researcher, osteopathic doctor, I can't remember, back in the 20s or something like that, where he found that if we are side bent in one direction, we are therefore rotated in the other direction. Well, in physical therapy and most medical approaches, when we see rotation, we try to fix the rotation without realizing that it's the side bending that's driving the rotation of the spine. So the easy way to understand whether you have a side bending problem is just simply take off your shirt and take a picture of your back. And if in those people with a side bending problem, which means that your pelvis is higher on one side and the rib cage is lower, usually on the same side, then you're going to have a larger crease on this side of your waist than you do on the other side. That's the easiest way to determine whether you have a side bending problem. But some people with side bending problems, especially if they've happened more recently, won't have that crease, because that crease usually is developed over time. And so I also offer a hands-on way of measuring whether you have a side bending problem. And that's by having a helper put their hands on the tops of your iliac crest here and also the bottoms of your rib cage to see if one side's higher than the other and so forth. Now, the thing about side bending problems is that they are very, very frequently, in fact, frustratingly so, diagnosed as leg length discrepancies. They are not leg length discrepancies. It is a compensation pattern your body has developed due to an older injury. And so chapter 7 is about identifying whether you have a side bending problem. And as you can imagine, if you have a side bending problem like this, it's going to cause unilateral back pain. It'll cause unilateral SI joint pain. It'll cause unilateral sciatic pain. So if you have unilateral pain or pain on one side of your body, then this is usually an indication that you have a side bending problem too.
I interestingly had a patient yesterday who asked me, I put way more weight on the one side of my leg. She came in for knee pain on one side. She has arthritis as well, but she goes, "Am I longer on this side?" And then I checked her pelvis. I was like,
Good for
"Here,
you,
let me
Mike.
look."
I'm
And
so happy to hear that.
I'm like, "No, actually, your pelvis is pretty level." I was like, "Okay." But
Yeah.
she was like, "Oh." I was like, "Most of the time it's muscle imbalances." She's like, "Oh." Yeah, it's kind of funny.
Yeah. Well, it's interesting that she would feel that, but not have it played out in her body, right?
Yeah, it was. I mean, she does have some valgus, so
Oh,
knock
okay.
knees more.
Yeah. Got
But
it.
yeah,
Or one foot pronated more than the other or something like that.
yeah, most of her pain was IT band insertion region,
Hmm.
but she's doing a lot better. Anyway, I
Yeah.
digress.
Good for you. Well, that's what this is all about. That's just now you can rule out a side bending problem as the source of that, and you can look at some other potential causes.
Yeah.
And that's what this is all about, is seeing the big picture of why pain is happening first. And then once you figure out that big picture, you can very quickly identify the sources of that problem.
I did tell her to stop locking her knees. She does it all the time.
Good man. Yeah. And by
So,
the way, this is kind of what you're describing, functional linking, right? Which is what chapter 5 is about, is introducing this idea of functional linking. So what you just said, I got her to unlock her knees. It was her knee locking that was contributing to part of the problem in her pain. So that is functionally linking a part of the body from one area of her body to another area. That's all functional linking is. And that's the idea I've introduced in chapter 5, which then helps you understand, why in the world am I testing my calf muscles if I've got sciatic pain, right? Or back pain? Because it all links together, and I explain how that links together in the book.
so chapter 9 and 10, you focus on tight thigh muscles, which can twist the thigh bone. So how can this potentially lead to pain down the line?
Okay, so there's actually two separate things. So tight thigh muscles. So let's go back to that extension problem idea again. We have too much arch in our back causing our pain. So naturally, it makes a lot of sense to, if you have too much arch and if your pelvis is tilting forward, then that's going to cause more arch in your spine. Well, what would cause the pelvis to tilt forward? Well, you just said one, Mike, and that is locking the knees. That automatically causes the pelvis to tilt forward. But from a muscular standpoint, the thigh muscles can cause the pelvis to tilt forward. And so if you have tightness in your thigh muscles, that will be driving the pelvis forward, creating an extension stress force to your spine. Sometimes this is symmetrical tightness, and sometimes it's asymmetrical tightness. If it's asymmetrical tightness in your thigh muscle, then you're going to, and I'm going to tilt this pelvis forward more on one side than the other. Now you can see that I've just created a side bending problem. So thigh tightness can contribute to both extension problems if you have central low back pain, or unilateral back pain by contributing to side bending problems as well. So that's where the thigh muscle tightness comes into understanding where it fits into your chronic pain pattern. The other idea I introduce into this book is something called femoral retroversion and anteversion. I call it the twisty thigh test. And basically, those are scary sounding names that basically mean our thigh bones are not all built the same. Some people's thigh bones are twisted outward, and that's called femoral retroversion. and some thigh bones are twisted inward, and that's called femoral anteversion. Females tend towards femoral anteversion. Males tend towards femoral retroversion. However, this is a spectrum thing, you know. So you'll find females with retroversion, you'll find males with anteversion, you'll find people with one thigh bone that's retroverted and one thigh bone that's anteverted. So we can't change the shape of the thigh bone, but with this knowledge, we can change how we use our body that will remove stress to our body, chronic stress, as a result.
So the next chapter 11, you talk about the importance of gluteal function. So we're talking about glute max, your butt muscle, glute medius, which are the side kind of hip muscles there. How does dysfunction in these muscles contribute to pain?
Yeah, so let's go back to, let's talk about anteversion, since we just talked about that's where the thigh bone is twisted inward, all right? So if your thigh bone is twisted inward, that increases hip joint compression. It also increases knee joint compression, and it drives more force into the tissues on the bottom of your foot, potentially causing things like plantar fasciitis or some other irritation like heel spurs, all right? So if we have a thigh bone that's already biased to rotating in all the time, well, how in the world are we going to control that? Well, the gluteus maximus, or the butt muscle, is an external rotator of the thigh bone. So if we know that we have femoral anteversion, then we have to pay special attention to the function of our butt muscles to counter or decelerate that internal rotation that's occurring as a result of how our bone is built. So this also plays out, the butt has a lot of different functions because it also helps orient the pelvis in different ways to remove extension stress or cause extension stress. The butt also has a large role to play in chronic hip pain and piriformis syndrome and all sorts of things. It is a central controller of the lumbopelvic complex. And so its function is critical to eliminating pain. And almost anyone who has chronic pain in the lower body system or low back has usually a butt functioning problem too.
So how do you fix the butt functioning problem?
Well, and there's two ways. We have to understand when do we use the butt in the first place? Well, we use it to walk. It has to be turning on when we're walking, and most people's walking patterns, it's turning off. So I show a technique in the book on how to change your walking pattern to naturally turn on the butt. And no, it does not mean pinching your butt cheeks together while you walk, which makes you look like you got to poop all the time, right? And it's completely unnatural because if you see a friend across the street and you wave, you've just unclenched your butt cheeks and you've lost your gluteal function. It's better just to fix your gait pattern and have it turn on naturally rather than have to think about that all the time. These are the types of solutions I have, is to fix the body naturally rather than forcing your body to do something it's never done before, all right? The other way is I have an exercise called butt pumps that actually targets the butt muscle to get it stronger and connect your brain neurologically to that faster. Because often, if your butt has not been turned on when you're walking over these past years, decades, whatever, then the brain is not well connected to the butt, and it's hard for that connection to occur again. We wake that up with a butt pump exercise.
It takes a long time. I've still been working on these things.
Yeah. Well, you were in a deep hole of dysfunction.
Yeah, I was. I was in years of dysfunction, apparently. Anyway.
Yeah. Well, this is the thing is, if you learn to walk correctly, you don't have to do another butt pump for the rest of your life. If the butt is working when you're walking, then there's no reason to really do any more butt strengthening exercises because it's functioning as it was designed to function.
Yeah, it definitely functions a lot more. Sometimes my hammies still like to engage, but it's a lot better than it was. I could tell because originally my butt was way more sore from certain activities like running and walking and stuff. So
for sure.
All right, chapter 12, we talk about foot and ankle issues. So can you share how problems in this region can affect the rest of the body?
Yeah, so let's say you have something like plantar fasciitis, all right? So it's an irritation of the fascia that's on the bottom of your foot, all right? And, symptoms of that is when you get up in the morning and your first few steps are really painful, maybe even feel like a tearing sensation on the bottom of your foot. Well, that's plantar fasciitis. So let's say that we can go back to that nail example that I had before. When you step on a nail, your whole body hikes up to get off of that now. It's same with if you have plantar fasciitis. Those first few steps in the morning, unless you're into, self pain, you're going to try and get off of that foot as much as you can. Well, you do that by basically hiking the hip up to get so that you're not weight bearing as hard on that foot anymore. Well, hiking that hip up is creating the side bending problem that I described earlier. And so if you have this plantar fasciitis or whatever pain in the bottom of your foot for a prolonged period of time, then your brain says, oh, that's what I need to do to get you off of this painful thing. Okay, I can do that. I'll just hold that pelvis up there. And now you've got a permanently elevated pelvis and usually depressed rib cage as a result, which is a side bending problem, which then causes rotation in the opposite direction. All right. So this is how foot problems can relate up to the pelvis and spine. And then, as you can imagine, if the pelvis is higher on that side and the rib cage is lower, it's going to compress nerve roots exiting the spine that comprise the sciatic nerve. And so it then may over time start to create sciatic nerve pain that runs down your leg. And then that sciatic nerve pain will result in weakness or dysfunction in the lower body system. So now, then when you go to a doctor, they say, oh, well, look at this. You've got disc bulges or foraminal narrowing happening in your lumbar spine. This is the cause of your sciatic pain. Well, no, all of those changes were likely caused by this older problem that's been going on and off for 10 years that has caused you to hike this up and caused all of this compression and adaptations to that compression, which then compromises the sciatic nerve. So fixing this stuff up here might be temporarily corrective, but if you don't get down to why it all started in the first place, then likely this whole pattern will be coming back again and again. All right. And so one of the things that causes plantar fasciitis is tight calf and soleus muscles, which I have you test in the book. You test those. If they're tight, then they can set you up for this whole chain of dysfunction going up to the rib cage and even up into the neck and head.
So I've had mild plantar fasciitis because I do distance running, and it's pretty calm most of the time, but I also play ultimate frisbee, which is kind of like soccer running for people that don't know what it is. But anytime I'm in my cleats, I swear I flare it up way worse. So I actually flared it up over the weekend because I played in a tournament. And that night I had to wear the dorsal night splint, and I could get up and it was a lot better because every time I get up before that, I was just like limping for a while. So the dorsal night splint does work.
Yeah, but you know what, Mike? It might be beneficial. You saw that I had that foot and ankle taping technique in my home program. If you did that when you were playing with your cleats, that will reduce the trauma to your plantar fascia because the tape is reducing the force that's being driven into the bottom of your foot in the first place.
Yeah,
so that might be a good solution.
I have some crappy cleats. I've had them for a few years, but it's really funny. That side, my heel and the insert is worn out, and the other side's fine. So I must be planting and running some weird way, or I cut a lot.
Well, is that your left foot that it's wearing out?
Yeah.
And do you kick with your right foot?
Well, yeah, but it's ultimate. I'm not actually kicking.
Oh, okay, that's right.
I was just explaining. You run and cut like most people.
Yeah. So most people, their left leg is their posting leg when they're running and cutting, and so that may be why that heel is wearing out more.
Sure. Yeah, it's also like I don't know. Those cleats just suck.
Yeah. Well, cleats by definition suck. So all the more reason. Even if you have a brand new pair of cleats out from the box, I would maybe think about, especially since your plantar fasciitis is a chronic problem, then I would think about taping during those games to eliminate even 10% of the stress that you're being delivered to that foot while you're playing.
Sure. Yeah, I actually had a different foot injury earlier in the season, and I had to tape it up. But I didn't know you. I don't think I have your home program, but
seems to be a pattern, huh?
It's all that left side. It's all that dysfunction. I know.
Oh, and what are we talking about? Oh, pain patterns. That's what it is.
Yes, Rick treated me in the past. I've had mild back pain on that side. I've had hip pain, and I have IT band syndrome on that side, and I also have plantar fasciitis on that same leg.
So you are a living example of functional linking.
Yes, I understand they're all kind of connected because it's the same side.
Yes.
Anyway, enough about me. Chapter 13, you discuss back pain while bending over. So, what are some ways this creates back pain, and how can someone fix it?
Yeah, so this is often the last thing that people think about to solve their back pain. Maybe they've done all the exercises and it's 90% gone, but I'm still having trouble when I'm vacuuming or I'm at the sink brushing my teeth. Well, that's because if let's go back to that idea of extension problems again, since we've been talking about that a lot. So if if you have an extension problem, it means that your spine stays locked in this arched position a lot. So that when you bend over to turn on, say, a kitchen sink or a faucet or something like that, your spine maintains this extension. And then when you come back up, you recruit even more extension to pull yourself back up. All right. And so the test I have for people is to simply bend over, turn on the faucet, and then come back up and then write down your results of that test. And so after you write down how you did that, then I show you ways that you're likely that you could change your body to do that differently to disperse forces along more tissues so you're not irritating your back and reinforcing that extension pattern of movement.
So, the next chapter 14, you explore neck pain and headaches. So, what are some simple assessments people can do and exercises they can try?
Yeah, so I think it's important. A lot of people with neck pain and headaches get left out with the chronic back pain talk, and they can be connected, and I'll show that connection in a second. But most neck pain and headaches are caused by dysfunction in the shoulder blades. And you can think of the shoulder blades as the pelvis of the upper body system. In fact, if you look at the bones, look at the pelvic bone here, it's flat, broad, flat, broad. It's the only two areas in the body where we have broad, flat bones. And so we know that the pelvis is the center of function for the lower body and back system. Equally, the scapula are the center of function for the upper body system. And so the most common problem that causes most people's chronic neck pain, headaches, or even shoulder pain is that the shoulder blades are resting too low. There are multiple reasons for this happening. We can go into if you want to, but basically I offer a really quick and easy test to determine if this is the source of your pain. If it is, I show you how to fix that. And so that's where this gets into it. Now, if you've noticed that you have neck pain or headaches on the same side that you have sciatic pain, then this is a real big clue that the side bending problem that you likely have is also informing how your shoulder blade is working. Because the shoulder blade rests on the rib cage. And if the rib cage is depressed because of a side bending problem, then that changes how the muscles that attach from the shoulder blades into the neck and head are functioning, causing chronic irritation to those tissues as well. That's how you can link those together. And so if your side bending problem is occurring because of plantar fasciitis in the same foot, now you've linked your foot all the way up to your head.
I feel attacked. I'm
just trying to help, Mike.
Fun true story. So my girlfriend works as a optometry tech, and she's obsessed with doing puzzles. So she's literally flexed over forward head position a lot, gets a lot of neck pain and headaches on one side all the time, and even shoulder pain, same side. And after talking to you for a while, one day I made her stand and looked from behind, and she had a side bending crease. And I said, "Oh, you have a side bending problem." And she's like, "What?" So I give her stretches and stuff to do, and it gets her out of the pain. But the problem is she gets stuck in those old patterns so much, it comes back frequently. But I thought that was pretty interesting.
Yeah, well, if you dive a little deeper, you'll probably get to the source of that, not only side bending problem, but also the shoulder blade dysfunction that's resulting from it.
Yeah, she does a handful of this stuff. That you've taught me over the years. So yeah, she does it. Seems to help a lot. Then once in a while it'll really flare up, and then she thinks she has to go to the chiropractor, and then they do a couple things and they're like, everything else you're doing is fine. I was like, told you. They just don't like to listen to their significant others. That's it.
I hear you.
So chapter 15, you talk about brain bias. So how does the brain's bias towards certain movements or postures that affect our pain patterns?
Yeah, so it's important to understand that, we're moving our body in a way that we've taught our brain to move our body. And so that's the whole purpose of practice. You practice so that you can neurologically embed a movement pattern to become more efficient at it. Well, if you've been doing that movement pattern over all of your life, it's become very efficient. And if you move out of that movement pattern, your brain is going to set off alarms. And so chapter 15 gives you a little test to do and we'll do it right now. If you just clasp your fingers together and without even looking at your hands, look at which thumb is on top and fingers. Which one is it for you, Mike?
My left. I did this at home. It felt very weird.
Yes. And so now, without looking at your hands, unclasp them and reclasp them with the opposite thumb and fingers on top. And we're going to hold them like this for a few seconds. Now, like you said, this feels very odd and weird, right? And so so that's our brain saying, whoa, 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 that's not how we do things. You've taught me to do it this way all the time. And so then if we hold it like this, at some point, you're going to start to get irritated that you're holding it like this. Like, I really don't want to be doing this anymore. And so your brain has created an emotional response to a simple change in function, right? That emotional response has nothing to do with which thumb and fingers are on top. It's just your brain developing a more robust response to a change in function. This is important to understand that this is how your brain is going to react when, for instance, I ask you to bend over and turn off a faucet differently, right, to relieve your back pain. Your brain is going to set off all of these alarms and say, whoa, 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 that's not how we do things. And then over time, that even may become an emotional response, like, I hate doing this, or when I ask you, teach you how to walk differently, I don't want to walk differently. That's your brain's emotional response saying, I don't want to change how things have always been done. The thing is that your brain doesn't understand that those neurological patterns are the things that have created your pain. Once you stay with those changes in your patterns and your pain goes away, your brain then will get the connection. Oh, that was causing this. Your brain doesn't have any way to figure out what is causing pain. That's what this book is for. You have to become an objective observer of your body in order to figure that stuff out. Your brain is too closely involved. And so that's what chapter 5 is teaching you.
It took me a good month until soft knee walking felt natural. And now, like, I've been doing it for a couple of years, and now it seems weird heel striking if I try to do it.
Yeah. And I'm glad you said that, Mike. That's exactly how it works. So once you deprogram these habits, these painful habits, and you really embrace them, your brain will then start sending messages when you're not doing it rather than when you are doing it. That's when you know you've changed your habit.
Yeah, I think you just discovered the new motor patterns, and then your brain just kind of figures it out. So, all right, the last question I have for you is: you discuss dietary sources of tension and the gut microbiome. Can you elaborate more on this?
Well, the gut microbiome has been a big deal in the news lately in the past year or so. There's a couple great specials on Netflix about it. I would encourage anyone who suspects that they have a gut or inflammatory issue to watch those specials to maybe learn more about it. I certainly am not an expert in the gut microbiome. I'm a physical therapist, but I understand that there's likely a connection, and I've seen that connection in a few of my patients who have had, like, for instance, celiac disease or mold exposure or allergens. What happens is their whole body moves into this inflammatory state. Well, a lot of times that inflammatory state will start to manifest in these three patterns of pain, and it will, like, kind of activate that fascia and lock you into that line of fascia or that neurological physiological pattern or the movement pattern. And so I just putting this on people's radar that, look, if you've struck out on every other thing, have you ever considered diet sources as a source of, why you're doing or responding the way you're responding? When usually with the patients I've worked with, when we work through all of the possibilities of why they're having pain, and then I start asking them about their diet and so forth, that ends up being a significant part of their long-term solution to their pain.
Sure. Yeah. No, if being very active and running marathons, if I go off of my normal eating regimen and eat something not as good, the next day I pay for it. It's like throughout my body and my stomach, and I'm just like, oh, that like 10 minutes of eating ice cream, I feel miserable today. Just gets to a point where it's almost not worth it.
Exactly. And so there is a connection there. And this is kind of the whole thing, in physical therapy, it's evidence-based practice all the time, right? But what if there's no evidence to support something that actually works? What we should be paying attention to also is practice-based evidence. That's what this is showing that if people are having success in practice, not using the evidence that researchers are focusing on, then maybe researchers should focus on what the practice-based evidence is to inform the evidence that they should be pursuing in their research, to then back that up and explain it. And that's what this book is offering, is a practice-based evidence model that I wish researchers would pursue. Might come up with about 40 different research areas and experiments to start researching this, but I'm not a researcher. I'm a clinician. And so I don't have the means to research this stuff. And so anyway, I don't know how I got on that tangent, but but yeah. So, it goes back to the dietary sources. No one's going to say, gluten is causing low back pain, but there's a lot of in-between steps to that process that it may be informing the fascial system or our, neurophysiological system that no one's really researched yet. And that's sometimes you just have to make those leaps and introduce the concept in order for people to be aware of the possibilities of these things.
Sure. So, is there anything else you would like to mention about the book that I did not ask?
Well, the book is all of the illustrations are in color. So I think that's really nice. And because it makes it more meaningful, you can see the connections better than if this was just black and white. Also, all of the tests and exercises have videos associated with them, which is kind of a feature in all of my books, because I understand that there's a lot of people who don't just learn things from reading words and looking at pictures. They actually have to see it being done in order to understand it. And you would access those videos by going to rickolderman.com website, and you'll see the place there under my books tabs. But I think the other thing I want to point out, Mike, is that a lot of the stuff I've said may have gone way over your head, and you may not understand even 10% of what I've just talked about in terms of the intricacies of the names of all of these complicated structures and pathways and so forth. That's not important for you to solve your pain. Don't let that stop you. This book is not written over your head. It's written for you. So the first section may feel like it's over your head, but like I said, I've condensed all of the information down into really easy to understand 2 or 3 takeaways. And then when you get to the tests, it's going to be meaningful, because you're going to test your body in a way, and you're going to start thinking about your body in a way that you've never thought about before. I really think this is going to solve, if not all of your pain, a large portion of it, and put you on the right road to recovery.
So this book is coming out what date? And you have digital versions and hard copies, correct?
No, I don't have digital versions. So I only sent that to you.
I'm
because
special.
It's not published yet. Yeah, because you're special, Mike, as we've learned during this podcast. And the book is going to be published. It's set to be published November 11th, but I think it'll be published before that sometime, maybe November 5th or something like that. So sometime in that area. I'm still working through this is just a proof copy, and there are a couple of errors I need to fix. So sometime around there.
So someone
I'll send you, Mike, the Amazon link to the book.
Okay.
And people can also go to my website and go to the books tab, and I'll have the Amazon link there as well, rickolderman.com.
So Rick, you have all your books there, you have your programs there, and people can even sign up for either seeing you one-on-one or group therapy as well, correct?
Yeah, so the group therapy is for those people who buy my home programs. because if you didn't have those home programs, you wouldn't understand anything that's being discussed in the group therapy.
Sure.
So everything's really affordable. And so for those who want more personal, um, connection and understanding of what's going on, and maybe some personal testing, that's what the group treatment coaching calls are for. And they're very, very affordable. It's super cheap. Yeah, that's how I've laid it out.
Well, thank you for joining us today.
Thank you, Mike. I loved your questions. Thank you for putting up with my tangents. I hope I didn't scare anyone away.
No, but I gotta start researching cytokines more because that term's stuck in my head now.
Yeah, well, don't kill yourself.